So the paper that I chose was this one, Preferences versus Practice, Life-Sustaining Treatments in the Last Month of Life in Long-Term Care, Biola et al. Just a little bit of background. I'm the current scholarship recipient for the PhD in aged care, so when we're looking at trying to implement antimicrobial stewardship in aged care. So I feel it still isn't working. Is there some, Phil? Sorry.
Yeah, it's just there.
Do I want to pick that instead? Sorry everyone, there's just a bit of a problem with the, okay, go that way. Lovely. So one of the things that they talk about in AMS and implementing AMS is this idea of low-hanging fruit. So what is easy to do, what can give you some quick wins, what can make an impact. And so when we're talking about end of life and aged care homes, the question of is there actually low-hanging fruit for AMS? Quick definition of end of life, there actually is no exact definition of end of life, but it generally refers to the last days or weeks of life, or the terminal phase, when somebody is irreversibly dying. So many illnesses, you don't die quickly. There is actually a period of time where you go through a dying process. And during that process, there is very common to get infections and febrile episodes, but as well as things like transient chemical pneumonitis when eating problems emerge. So it is actually very common that antibiotics are used at this point in time in somebody's trajectory of illness. There's conflicting evidence about the usefulness of antibiotics during this phase. And in trying to find some low-hanging fruit for AMS, if you're trying to get, and it's very difficult to, because you're also dealing with vulnerable populations, you're talking about death and dying, and you're also talking about transgenerational ethics. And so my hope was that this paper at least pointed in a direction that might help us find an area for AMS at end of life and aged care homes. So if we're looking at the goals of end of life care, you're looking to maintain comfort and choices and quality of life of a person who's recognized as dying. You're looking to support individuality, and you're looking to care for the psychosocial and spiritual needs of the individual and family. And this definition sort of suited my purposes very well, because at 2 different points they talk about this idea of choices, and they talk about supporting individuality. So in most of the English-speaking world, if not all, I don't know for sure, competent adults can refuse medical treatment. It's well ingrained in principles of autonomy and principles of Western medical ethics that a competent adult knows what's best for them. So if we're looking at optimizing antibiotic use at end of life, it would be suboptimal use to be giving a bunch of antibiotics to people who actually don't want them, who have made choices of their own not to have antibiotics at this point in time in their illness. So getting back to the paper, the purpose of this paper was to determine the prevalence and correlates of decisions made about life-sustaining treatments among residents in long-term care settings, including how often decisions were honored and the characteristics associated with the decisions not being followed. And they look at antibiotic use. So this was data from a larger end-of-life and long-term care study, which was done quite a long time ago now, 2002 to 2003. Much of the work was done in this area in the 90s and the early 2000s in America. There was a case of Terry Shah, who was a very young woman who was in an aged care home for 15 years. And her husband and her parents fought 14 different court cases over 15 years about her NG tube, which was feeding her and sustaining her life. And because of this, and because of the prominence that this had in America in the papers and in the court system, there was a lot of work about advanced care directives of this kind during the 90s and the early 2000s. Advanced care directive works has since moved on from this kind of asking people, what you want and comparing it to what was actually given you. So a lot of the work in this area is quite old now. The paper looked at 230 long-term care facilities in 4 states. And of them, 31 were nursing homes and 199 were resident care assisted living. So a nursing home is a higher level of care, usually 24-hour medical care, versus assisted living or residential care, which generally has an older population, and they generally do need assistance in at least one activity of daily living. So they did retrospective interviews with family caregiver and a staff member who, best knew the residents as identified by the facility liaison. It was retrospective after the death of the resident. They did quite a number of interviews, 450 family and 675 staff interviews for a total of 792 residents who had deceased. And of that, 327 had data from both family and staff members were included in the study. So the family caregiver was asked, was a decision ever made, not just in the last month of life, in discussions with the doctor about whether or not to give antibiotics in case of infection? There were some other life-sustaining treatments included in the question as well. And then they asked, what was that decision? And then they asked the staff member to report the life-sustaining treatments the resident received during his or her last month of life, including the antibiotic use. Now, this obviously isn't the ideal study, and this was the part of this that I found quite disappointing. The use of retrospective memory, particularly for the staff member, it would be very hard for me to believe that a staff member would remember every life-sustaining treatment, including every course of antibiotic that somebody received even 6 months before. So you would imagine that a lot of the staff members took a look at the notes, but it certainly doesn't say that in the paper anywhere. So you would imagine that a lot of life-sustaining treatments were left out of this cohort in the study. When you're talking about retrospective memory from family members, particularly around times of stress, people can have false memories. They can want themselves through guilt or through bereavement to want to make them look like they were much more involved in the care of their loved one who died. So you would think in that case they could have been over-reported the decisions that were made. And in fact, just skipping a little bit to the results, they do say that the decisions were over-reported as compared to other, when they look retrospectively at case notes. They don't cover, the question they asked was quite poor, so they don't really cover changing directives or changing decision. They just ask, was there ever a decision? So there could be a decision. There could have been a decision, well, we're not going to give antibiotics tonight to mum, but if she hasn't improved by tomorrow, we will. But that kind of circumstance wasn't at all covered in the study protocol. There's a difference between decisions and orders. So it's much easier to make a quick decision than to actually have a physician write down a do not hospitalize or do not resuscitate order. And I have a slide later on where I'll show you some of the differences between people making those decisions. So just, quickly saying, no, we're not going to give antibiotics to mum tonight is different from saying, I want it written down in her case notes that no antibiotics. So the correlation between the decisions and what was actually done can't be accurately identified because there is a difference. Family caregiver's decision, that was the other thing that was very unclear about the paper, was that they don't ask specifically, well, what's the decision of the person, or what's the decision your decision as a family caregiver? They just talk about the decisions. So these two papers show that family caregivers are far more likely to overtreat. So if you ask your surrogate, you ask your family member, they're far more likely to decide to go ahead with something than what the person actually would request. And the Shalowitz paper shows that family caregivers actually only get it right in about 30% of the cases. So 30% of the time, in less than 30%, in more than 1/3 of the time, family caregivers don't get it right what you want. So there is some gap there between what a family caregiver's decision, what your surrogate decision is, and what the actual resident's decision. And the last thing that's important to, I guess, gap or let down in this paper is the fact that concordance with directives cannot be equated to better end-of-life care. So it's not the same thing. So just because you're following what is being asked doesn't mean that that is actually a better way to go about doing it. I guess the saving points about the way that they've done this study is that it's actually very hard to, or you're limited in your choices when you're studying end-of-life care, especially retrospectively, because a person's not around to ask, how was the end of life? That just doesn't, it's one of those null states, you can't do it. So I'm sure there was some convenience, methods of convenience in the way that they designed the study. And retrospectively, you're limited to looking at the case notes or speaking to the staff and the relatives, which they've done in this case. Prospectively, end-of-life care is usually done with validated symptom and validated pain tools repeatedly over a period of time. So that's what they look like in end-of-life care usually. And also the primary outcomes in end-of-life care research is based on symptom control and pain relief. You can't look at mortality, you can't look at that kind of thing for end-of-life care. It's really limited in the scope of what you can do. And the other point I wanted to make about this is that the definition previously is that you can't also just completely disregard what the family member's memory was. Family members are involved in end-of-life care. If you remember the decision at the start of the presentation about the family members, that is actually included in really the holistic look of end-of-life care. And also, if someone's going to complain, or worse, someone's going to sue because of an end-of-life decision, it's going to be the family member, and it's going to be at least initially based on what they remember. So it can't be completely disregarded, I guess is what I'm saying. So if you look at the results, so 327 residents, more than half are female, what you would expect. The average age over 80. 66% said there was a slow, steady decline. And an important thing in the results, and maybe the most important thing that I took away from this, was this: over half of the people said that they expected death imminently. So they answered yes to the question, did you know that his or her death was days or weeks away? This is important because it's important that you can recognize the end of life if you are going to give somebody end-of-life care. So if you are going to change the philosophy of care instead from cure to care, so you're no longer looking for life-prolonging treatment, you're looking for treatments for comfort, you have to first be able to recognize that somebody is dying. That end-of-life care is something that is appropriate. So in this case, for long-term care residents, over 50% of their family members said that they recognize the end of life. Just quickly on some of the other life-sustaining treatments. So they also looked at CPR, feeding tubes, and do not hospitalize orders. 95.5% who reported decisions decided not to be resuscitated, and 92.9% reporting a decision decided against tube feeding. So this just points out that people who live in aged care homes, in nursing homes, are willing to forego life-sustaining treatment. Quite a large percentage of them as well. Do not hospitalize orders. So this was a little bit, it wasn't as, I guess, prominent, or it wasn't quite as obvious in the decision to forego, but still 45% of the people who reported a decision reported not to be hospitalized, and a discordant hospitalization was more likely to occur in a nursing home, so more likely to occur where there's a higher level of care, which probably is not surprising because some of the risk aversions and paternalism that can happen when people are unwell. So antibiotics, this is what we were really interested in, or what I was really interested in. So 64.6% reported having a discussion with a physician about the use of antibiotics. I thought that was great. I didn't think that it would be that high. And again, you have to understand some of that retrospective memory issues and some of the issues with participants wanting to seem more involved in the care than they actually were. But that was a lot higher than what I thought it would be. Most people spent more days visiting the facility in the last month of life. Not surprising, if you're there when the decision needs to be made, you're more likely to be involved in the decision. Those residents were more likely to be on Medicaid. I love perverse incentives of the American medical system. When Medicaid, you can't pay for something, so we'll actually ask you if you want it. And more likely to live in a larger facility. That might be an issue with infection in a larger facility, I'm not sure. And more decisions were reported in nursing homes and in the lower level care settings, which could have to do, again, with the characteristics of the residents in a nursing home. You're more likely to have infection at end of life. So this is the part that gave me great hope, and then realized that I couldn't really make the conclusion that I wanted to make. So 34.6% received antibiotics in the last month of life, as reported in this study. Other studies looking at aged care report statistics about 40% of people in the last month of life receive at least one antibiotic. And so 69% of receiving antibiotics reported a decision with their physician. And this one, so 19.2% of residents who received antibiotics had a family caregiver report a decision not to use the antibiotic. So I wanted to make the conclusion that 1 in 5 antibiotics given to people at end of life were actually given to people who didn't want them. You know, that's the conclusion I wanted to make, but you can't make the conclusion based on the unfortunate way that they did the study. But maybe it points us in a direction. Maybe it points us somewhere to have a look at the people who at end of life are receiving antibiotics who actually don't want them. Because there is, like I said at the start, a strong argument that it is suboptimal use of antibiotics to be giving them to people that do not want them. So, and again, people who received antibiotics and had a decision reported not to use them were older. And that's supported in the literature as well. Nursing home residents who are older are more likely to have their decisions overridden by a surrogate or a member of staff, even after that person has told somebody and spoken about the decision that they would make. So is there actually any low-hanging fruit for AMS in respecting choices of people who do not want them? You know, can we improve, can we optimize the use of antibiotics in this area by actually just looking at the choices that people would make? And what impact would this have on total inappropriate antibiotic use at end of life? So if anybody, this was part of my reasoning for bringing this up today, is if anybody knows of any other papers that actually do look at people in nursing home and their views on antibiotics at end of life, I have my data, or I have my email address at the end of the slide. I'd love to hear from you because this is what I've been able to find thus far. And this chart is really interesting. There's some really interesting things about this table. To start with, you can really see the difference in making a decision and making an order. So the first two research studies were done with somebody who was just speaking to a research assistant. So the decisions that they were making actually had no consequences. You were just having a conversation with somebody. And so in that cases, you get up to 75% of people say that they would refuse antibiotics if they had end-stage dementia. You know, that's a huge number, but it's a decision that was made that had no consequences. The second one down, the Garcia et al., is an interesting and brings up an interesting point because the people that they were speaking to had mild cognitive impairment. So in Victoria and in most places, you need to have capacity to make a decision. So just if you are an adult and you do not have legal capacity, so if you have dementia, you can't make that decision to forego antibiotics. Somebody has to make that for you. But even in that case, you're looking at, you know, they asked the question, if you were dependent in all activities of daily living and had an inability to interact with or perceive your surroundings, you know, you're looking at 61.5% of people would refuse antibiotics at that point in time. So the next one down is the study we were looking at, and the bottom two are nursing home residents with a POST. So a POST is a physician order for life-sustaining treatment. It was something that started in Oregon in the 90s and is relatively well evaluated at this point in time. And they are designed only for people who have serious illness or whose physician would not be surprised if they were to die within the next year. So that's, funnily enough, is one of the best predictors of mortality in older people, is if, you know, if you ask the doctor, you know, would you be surprised if they died the next year? And the doctor said no. You know, that's as good as any when it comes to predicting death, interestingly enough. But So that's an actual order. So that's a physician order for life-sustaining treatment that goes into your medical record. So you can see the percentages creep down. You're not looking at 75% of people saying that I don't want antibiotics if I was, now that I'm living in a nursing home. You're looking more as, 35, 40%. And the other important thing is there's different versions of this physician orders for life-sustaining treatment, but whoever wrote it, I suspect there must have been quite a influential infectious diseases physician, because antibiotics gets a great deal of importance in these forms. So they ask about 4 levels of care, or 4 modes of care at end of life for life-sustaining treatment. They ask about CPR, they ask about whether you want to be hospitalized, they ask about other medical interventions, but then they actually ask, there's a whole section on the form about antibiotic use. So antibiotics has really been elevated in these forms to life-sustaining treatment and is recognized as life-sustaining treatment. And they give the options that you want no antibiotics, you want limited antibiotics, or you want full antibiotics. So limited antibiotics is defined as antibiotics only for comfort. And that brings up another important point. In Victoria, the law is such that you can refuse medical treatment, but you can't refuse palliative care. So it becomes an issue of whether or not antibiotics is seen as life-sustaining treatment, such as it is in this case, or if it is seen as palliative care, comfort care. So how much time do I have? So then I went and had a look at what the palliative care people say about antibiotics, because they would know the best. So this is a fantastic quote: antibiotic overuse likely affects poor quality care in palliative care hospice settings. And they've had this conversation in palliative care about the use of antibiotics and its role in palliative care. And this was a fantastic table that I did while I should have been working on my confirmation, really, because it probably doesn't relate so well as much as I wanted it to nursing home care and care at end of life in residential aged care, because I think the populations are just a bit too different. But the very last column is the percentage of people who received at least 1 antimicrobial in palliative care. And while the populations are quite different, I would draw your attention to Dwyer et al., which is about halfway down, because that was a representative sample of all hospice or palliative care agencies in the USA, and only 49% of those people had a primary diagnosis of cancer, and they were looking at people who were over the age of 65 years. And they looked at the last week of life, and you're looking at about 18% were prescribed at least 1 antimicrobial in that situation. The O et al. Research, or the O et al. Study, that's the one that gets held up in palliative care circles as overuse. So in that case, it looks like there was just a habit that was going on in the inpatient unit in Seoul, that just about everyone got some sort of antimicrobial that they're on. Because I kind of stopped working on this because I realized it was more of a distraction than anything else. Nothing's been adjusted for time, but if you are looking at unadjusted for time, you're looking at about 26% of people get an antibiotic in palliative care. And if you're looking at the last week of life, you're looking about 27%. So it's lower than what the stats are for aged care. But it certainly provided some sort of direction and guidance. But it occurred to me that I had no concluding slide, and that's pretty much because I have no conclusions. So this is kind of what we're working on for the next 2 years, is trying to find some sort of AMS intervention that, might help both improve care, because we are cognizant of the fact that we're looking to improve care. We're not just looking to say that people who could benefit from antibiotics in their life shouldn't have them, but certainly the stats as it now, it doesn't look as though that distinction between life-prolonging treatment and comfort treatment is something that's necessarily considered. And yes, so watch the space. So. 2 years from now, I might have a concluding slide for you. But if anybody knows of any other studies in nursing homes where they've asked people about whether or not they want antibiotics, I'd love to hear from you.
What advanced care directives in Australia, do they say anything about antibiotics?
No. So there's lots of them. In Victoria, the Advanced Care Directive form, which is promoted by the Office of the Public Advocate, there's nothing. It's just life-sustaining treatment. The refusal of treatment form, you can refuse all treatments, which includes drugs, or you can refuse. But it's just it's not elevated to the status where it looks like people are considering antibiotics as life-sustaining treatments. You know, if you have a doctor who considers it as a life-sustaining treatment, it might be included in your advanced care plan, but it would help if it was on the form, which, you know, that's why this group in Oregon who have put together this physician order for life-sustaining treatment, I assume there must have been some infectious disease physician who got it on there because it's certainly a priority for people to consider.
I have to think some of these residents are posting their last days or weeks can't take anything orally. So are they intravenously or intramuscularly giving these?
Yeah, they can be. They can be. And there's lots of literature on, you know, the pain and suffering and prolonging life and all that kind of thing, which antibiotics at end of life cause. And orally, there seems to be less pain than intramuscularly, which, you know, would make sense, right? But it happens, is what it's saying. And I don't know if it's a problem with recognition that this is end of life, or if it's, you know, you don't know, and that's part of what we're doing. So it does happen. It does quite happen a lot. One of those palliative care studies looked, you know, exactly at that, just like intramuscular, antibiotics end of life. So it happens.
I was wondering about that as well, and that whether the decision making, how influenced that would be by route of administration, and that, look, I just don't want any more tubes put in mum. What you put in the tube is it's actually the administration.
Yeah, so
that if we're going to give them antibiotics, it's going to be daily injections, and they're deciding if it's injections they don't want.
So one of the studies asked about, you know, intravenously or orally, and a higher proportion of people said that they would forego, you know, intravenous antibiotics, which would be suspected. So,
one more question.
I was just wondering about the term antibiotics for comfort. What the hell that would mean?
I thought that was morphine for comfort itself.
Well, okay. So again, in the palliative care circles, they've done these studies about people who receive antibiotics while they're receiving palliative care as well. And so it's for symptom relief. So it gives them release of symptoms. And the way they study it is by validated pain tools over, you know, a period of time, looking at whether or not their pain subsides or their symptoms subside. And unfortunately for the aged care setting, if you know anything about antibiotic prescribing in aged care, the one indication where there actually seems to be good evidence for comfort are UTIs. So there is, you know, evidence that if you have a UTI and you're in palliative care and you receive antibiotics, it will help with your symptoms. But for everything else, no, it's not.
Thanks, Leslie. Thank you very much. You're not well. Oh, really? Next one on. So that's it.
I can't see. No, that's okay. That's right.
Okay. This is what people online will see.
Okay.
Good.
Thanks, Phil. So I'm Kathrin, the AMS pharmacist across the road at Royal Melbourne Hospital. Apologise if my voice sort of runs out, I'm a little unwell, but I'll try my best to get through it all. So today I'll be talking about a systematic assessment of review to promoting the appropriate use of antibiotics through hospital electronic prescribing systems. So this was published in the International Journal of Pharmacy Practice just recently, last month. So I guess we've got an interest in this area, given that, well, in our group here, we've got a keen interest in how technology can support antimicrobial stewardship, but also, I guess, with electronic medical records and electronic prescribing systems becoming increasingly incorporated into hospital systems across Australia. I wanted to have a look at what sort of work's been done in this area and see what sort of outcomes have been reported.
Just use the mouse
Okay. Sorry.
on the left hand. Just bring it over here.
Okay. Okay, so obviously I don't really need to tell this group here about the threat of antimicrobial resistance being exacerbated by inappropriate use of antibiotics, and basically, we all know together here that we need to maximise the effectiveness of the existing antibiotic treatments that we have, and do this through resources that facilitate optimal use of antibiotics in humans as one key approach to reducing the risks of AMR. And we know that the focus on appropriate use of antibiotics in hospital settings is really based on organisational approaches to promoting and monitoring judicious use of antimicrobials. And this is through the national standards, the requirements for hospitals now to have an antimicrobial stewardship service in place that does look at promoting and monitoring use of antimicrobials. This looks a bit different. We also know that systems can potentially offer considerable support for many aspects of the appropriate use of antibiotics in hospitals. So evidence from other areas has shown significant potential for computerised physician order entry, which will be referred to as CPOE, and also for computerised decision support, or CDS systems. However, we don't know for sure how these relate to antimicrobial stewardship. And with e-prescribing systems becoming increasingly embedded within hospital information technology infrastructures, we know that there's this opportunity now that exists to develop interventions that support all of the key decisions that occur within the antibiotic prescribing process. But there's uncertainty about how these interventions are optimally conceptualised and deployed in this setting. So the objective of this paper was really to identify and to describe the existing and emerging approaches to promoting appropriate antibiotic use through hospital e-prescribing systems. So as they didn't really set out to draw any definite conclusions about what types of e-prescribing systems lead to optimal outcomes or which functionalities are most optimal, but they wanted to describe what there currently is out there in the literature around this. So they looked at both standalone and integrated systems. They also wanted to identify any gaps to inform future efforts, and they set out to do this using a systematic scoping review of the literature. So what the authors did is they searched the published literature from 1997 to September 2015. They chose 1997 as their starting year based on this being when the first IDSA guidelines on optimal antimicrobial use in hospital settings was published. So that seemed reasonable. They looked for work investigating the use of e-prescribing and associated health information technology systems to improve appropriate use of antibiotics. And they specifically looked at this in the hospital setting as well. So the databases that they searched included Medline, Embase, Cochrane database, some clinical trial registries, looking for work that was in progress, and they also said that they looked at Google Scholar to identify any other potentially eligible studies. So the search terms that they used related to the different components of the e-prescribing system. So there were 3 groups of search terms that they used. So the first group of terms was related to the functionality associated with the e-prescribing system. So terms like electronic health record, electronic prescribing, e-prescribing, clinical decision support, computerised physician order entry. The next group of terms that they looked at were with regard to appropriate use of antibiotics, so antibiotic, antimicrobial, stewardship, those sorts of terms, drug resistance. And finally, they searched for terms relating to the hospital setting to try to narrow it to that area, so just terms like hospital, tertiary care, intensive care, emergency, etc. And then the terms within the 3 groups were combined. They decided to include experimental studies of various designs, and they did exclude low-income countries because they thought that the different contextual circumstances would mean that the outcomes would be different in that setting. So that's just a flowchart of the search strategy. So they started off with 3,434 records that they identified through the database search, plus an additional 38 through other sources. So I think they mean through the Google Scholar search. So originally they just screened titles and abstracts, and then after removing duplicates, they screened 3,402. They excluded 2,981 records after screening the abstracts, which is a huge number that they excluded. They don't go through in detail the exclusion criteria other than that they excluded any studies that fell outside our scope of interest. Yeah, so it's quite a lot that they narrowed it down to. Then they read the full texts for 421 articles, again excluded 276, and ended up with including 143 studies.
Is there an issue with the slides? We're getting some questions.
Yeah, they're not moving. I don't know why.
Do you want to have a look? I think it says slides now visible.
Is it still in the title, Caroline?
Yeah, it is.
Yeah, I've got no idea why. Sorry. Yep.
Still on the title. Just stop showing the screen there. Yeah, it's moved.
It's moved?
Yeah.
So we're on this?
Yeah.
Yep. It's not moving.
It's stayed on the side slide. Yeah, it's changed.
Okay.
Yeah.
So,
Okay.
with you.
Okay. So 2 researchers, well, basically to get to that stage of the 143 studies that they included, there were two reviewers that independently screened all the articles, and then they discussed them and resolved any discrepancies. And then there were 2 researchers who independently undertook data abstraction from each of the 143 studies that they decided to include. So basically there were 3 main steps for the interpretive synthesis of the findings. So they looked at firstly the range of functions and uses of the e-prescribing and related systems to promote AMS. So what was the actual functionality of the system. Then next they looked at developing a synthesis of the findings, so what sort of outcomes were reported for each type of system, and then they did attempt to look at any relationships in the findings as well. So just to move on to the results, so there were 143 studies included. Just to break down the types of studies that they identified, vast majority were observational studies of retrospective nature, which is probably expected. They did find 9 systematic reviews, 5 surveys, and 2 randomised controlled trials only. 5 of them included a qualitative component, so it's not very many, obviously, out of the total that they looked at. In terms of the locations for a lot of the literature around e-prescribing, most of it comes from the North American states, with the second most actually from Australia, and a lot of that work is that was included in this review was from the group here, which is great. And then after that was the UK, France and Canada, the next most literature in this area. So they looked at where most of the evidence lies with regard to e-prescribing and found that it is mostly in specialty settings, so such as intensive care, emergency medicine and in paediatrics. They found that a lot of the literature is also with regard to high-risk patient groups like immunosuppressed patients, and a lot of it is done in tertiary care settings, which is also not surprising. Most of the literature they found related to computerised physician order entry as well as computerised decision support, and it mostly focused on interventions that targeted individual prescribers, so things like prompts and reminders was most common. Most of the work related to homegrown, standalone sort of systems that were implemented in single centres only rather than more integrated systems, but they found some papers relating to complex integrated systems where there was integration with the medical notes, pharmacy systems and lab results as well, but this was much less common. They did note that the functionalities across the different systems varied significantly, so it did actually make it difficult to compare the different functionalities. So they weren't able to draw any conclusions about the different types of systems. But we'll go through the different outcomes that were reported across the literature. So they found that the outcomes were in these 3 categories, with healthcare professional performance being the number 1 outcome that was investigated by most of the studies. So with regard to professional performance, there's a breakdown in that table of what was normally reported. So outcomes like the antibiotic choice, turnaround time for first dose of antibiotic, optimal dosing, adherence to guidelines and total antibiotic use all fell under that category. The next most common outcome to be reported was patient outcomes, mainly looking at adverse drug reactions, mortality and length of stay. And finally, cost effectiveness was rarely reported in the outcomes around this literature, but when it was reported, it was looking at total antibiotic expenditure, future resistance in a very few studies and the cost related to that, and then cost of hospitalisation associated with antibiotics as well. So the studies that reported on practitioner performance generally reported an improved time to first dose of antibiotic associated with the e-prescribing system, improved selection of antibiotics, optimal dosing, improved guideline compliance, decrease in total antibiotics prescribed, reduction in errors, increased de-escalation or earlier cessation of antibiotics, and there were reports that said that the e-prescribing systems allowed them to identify prescribers who performed the best and also those who performed the worst. So I guess there's a benefit in that, given that you can then target prescribers who are, I suppose, not complying with guidelines or making the most errors and target them for further intervention. So I did look at some of the studies that they had included in their review just to highlight, I guess, some of the different types of functionalities and e-prescribing systems that they included. So this one, maybe people will be familiar with, it's work from here. This one was a computerised decision support system using an algorithm for CAP severity and antibiotic recommendations. So this study was sort of a standalone study in a hospital that doesn't have an electronic medical record, but this computerised decision support system led to improved appropriateness of antibiotics prescribed and guideline compliance, and also improved time to antibiotic in the ED. and that was compared to academic detailing. Now, I wanted to look more at some hospitals that do actually have an electronic medical record, particularly some of the hospitals in America that use Epic. This is an electronic medical record that is becoming implemented in hospitals across Australia, and it's one that our hospital is looking at implementing, hopefully maybe in the next 5 years or so. But I thought I'd see what types of antimicrobial stewardship interventions and e-prescribing systems can be used in this setting. So this study looked at and they incorporated an order set, including evidence for the benefits of antibiotics in the setting of acute upper GI hemorrhage in patients with cirrhosis, and that was integrated into their electronic medical record. And the outcomes for this study was that the administration of antibiotics in this setting, when they were indicated, did increase. So it led to increased appropriate antibiotic prescribing and also reduced time to antibiotic. This one was where they, in a hospital that also had computerised physician order entry, and the intervention was that there was reference text incorporated into the electronic medical record that would prompt the physician to select the recommended perioperative antibiotics for this given surgical procedure. So it would provide the guidelines for which antibiotics should be selected perioperatively. And having this reference text in the EMR did lead to a significant increase in the number of patients receiving the appropriate antibiotics. This one again had an electronic medical record alert that was implemented for patients with renal impairment, and the intention of this was to reduce dosing errors in patients with renal impairment. So for selected antibiotics that required dose adjustments, an alert came up to remind the physician that dose adjustment was required, and dosing errors were significantly reduced after this intervention. So yeah, that was basically just showing some of the different functionalities that were used. Next, for patient outcomes, they reported that the most frequently reported measures with relation to patient outcomes were adverse drug reactions, mortality, length of stay, emergence of resistant pathogens, and reduced rates of drug reactions. And finally, for cost efficiency, this was really least frequently examined in the literature, but some studies did indicate that the e-prescribing system led to cost savings relating to antibiotic expenditure and also cost of hospitalisation through reduced length of stay with appropriate antibiotic prescribing. So they did report benefits in most of the studies that were included in this review, but benefit was not always reported. They found that some of the studies reported a lack of impact on practitioner performance and patient outcomes, so sort of a neutral effect. They did say that only one study reported worse patient outcomes associated with an electronic allergy label. I don't think that would really be related to the fact that there was an electronic label though. I think it's probably more to do with the fact that the patient had the allergy label that was leading to their poorer outcomes, because we know that patients with multiple allergies often receive less optimal antibiotics. And they also noted that some of the studies demonstrated no cost savings or actually increased costs despite improved quality of prescribing. But I did have a closer look at the studies that they referenced that said they demonstrated no cost savings or increased costs, but in reading some of those abstracts, that's not how I had interpreted the information. The way I read it was that they actually led to cost savings, so I wasn't completely convinced about that statement there. So we could see that there were conflicting findings across the range of different e-prescribing systems and the literature that they found. So the authors concluded that this was likely due to the social context in which these systems are used. So from the studies that they found, there was documentation that the clinicians may have rejected some of the system recommendations, maybe because they didn't agree with the recommendations that was being made by the systems, and also some clinicians reported difficulty complying with guidelines in general. Didn't go into the reasons why they might have difficulty, but it may be just due to their prescribing habits or not agreeing with what's in the guidelines, or maybe lack of availability of the antibiotics that were recommended in the guidelines, for example, but they reported that having the system in place made no difference to what they would prescribe. There were also reports of changes in workflow associated with the e-prescribing system contributing to lack of benefit. And further to that, some systems were reported to adversely impact on user time, and that time increases for the clinical users actually was increased with some of the systems that were implemented in these hospitals. So I guess that leads to some possible lessons about e-prescribing systems, that we do need to have a focus on the usability of the system and making sure that it does fit in with clinician workflow for it to have the benefits that it's set out to have, and ensure that they're deployed as part of a wider organisational transformation and pay attention to the different contexts that they're used as well. So they also looked at interventions that had sort of a broader organisational focus and that reused data that was held within the systems. And actually there's not much evidence around this from the literature review that they did. So they found that work on multifaceted and multidisciplinary interventions was quite rare. They only noted a couple of exceptions to this. So they found one study that looked at high-risk orders triggering a pharmacy intervention to complement computerised physician order entry, and another study where the system linked physician order entry with pharmacy dispensing to lead to faster time to antibiotic. So I'll just quickly show you those ones as well, because these were quite different to a lot of the other studies. This one was a surveillance application that was implemented to enable pharmacy review of high alert medication orders to complement their existing computerised systems for physician order entry and for clinical decision support as well. So I guess this was in a setting where they already had these electronic medical record systems in place, but they were still able to come up with an intervention to prevent further patient harm. So basically they integrated data from the different clinical systems available in the hospital. There was a background algorithm to highlight high-risk scenarios, which triggered a pharmacy alert, for example, for all patients who were prescribed an aminoglycoside. So the pharmacist would review those patients within that day, and it was very frequent for interventions to prevent further patient harm for patients on aminoglycosides to be reported. This one looked at the impact of electronic order management on the timeliness of antibiotic administration in critical care. So this one, there was an electronic medication management system that included the computerised order entry, and then it was linked to pharmacy order processing. So this is where, I guess, once the order is entered into the system, it would directly link to the pharmacy so that dispensing can occur basically at the time of the order being entered, and the pharmacist can check it at that time as well. So this showed that this system led to improved timeliness of antibiotic administration in these patients. It may not be as relevant here where we actually have the drugs available on the ward, whereas in America, every medication that is ordered through the electronic drug chart needs to be dispensed. So this sort of integration would definitely help to get the antibiotics dispensed more quickly. So when they looked at reuse of data from the e-prescribing system or from other systems available in the hospital, they really found limited studies that drew on data that already existed. They found limited studies that said that reuse of data could be used to predict appropriate therapies and doses for high-risk patients such as immunocompromised or patients with renal impairment, but there's very little work on this reported. This is just an overview of, I guess, what they looked at. So system functionality, which they found was mostly CPOE or computerised decision support, as we've gone through. Then the outcomes, majority of the outcomes reported was on individual performance of the prescribers, and then further down, some outcomes looking at cost and patient outcomes. And context of use mainly individual, so focused on individual prescribers and individual settings rather than integrated within the whole organisational health system. So overall, they said that they found mostly small-scale studies with designs that were prone to bias, I guess because mostly they were retrospective, non-randomised studies, but that is what you would expect for this type of work. CPOE and CDS were most common, but they did vary widely. So this really complicated meaningful cross-study comparisons, unfortunately. They said that there was lack of insights into unintended socio-technical consequences of interventions. So leading on from that, basically when we're thinking about this in the future, we know that there can be difficulty in evaluating these sorts of interventions due to their complexity and also multiple components within these sort of systems, and that they will often also be accompanied by other changes that are occurring within the organisation at the same time. So it's hard to know which effects are due to which intervention that was implemented. But there is a suggestion that embedding qualitative work within the research can assist and include insights into things like alert fatigue and time impacts of systems. So these are important to assess when these sorts of systems are being implemented as well. And they did come up with this conclusion that they thought that interventions that draw on electronic data held within systems are likely to present the biggest returns on investment, but it's currently very scarce. So I guess from our point of view, we need to have an integrated electronic medical record to be able to draw on data from pathology, for example, lab results, pharmacy, to be able to implement these sorts of interventions. But at the moment, we don't have that option. So we know that these systems clearly do have the potential to improve patient outcomes and improve antibiotic prescribing, but more rigorous multifaceted interventions need to be developed and evaluated carefully to be able to take this work forward. We know that lots of different options exist for the types of functionalities and interventions that can be implemented in e-prescribing systems, but whatever the approach is taken, it's important that appropriate organisational and social components play an essential role in that. And basically this is really just provide an overall picture of the current evidence surrounding these approaches to promote AMS through e-prescribing systems, but this work really needs to get taken forward as a basis for designing and formally evaluating interventions and the impact on patient outcomes, which these authors say that they are progressing with now. But yeah, unfortunately, we don't have any amazing conclusions from this. It's more descriptive sort of work of what type of work is being done and what literature is available at the moment around e-prescribing. That's all. Thank you.
Thanks, Kathrin. Probably got time for one or two quick questions if anybody in the room has got any questions. Or anybody online, any questions? No? Okay. All right. Thank you to both Leslie and Kathrin this morning, and hopefully we'll see everybody in a month's time. Thank you.